to the next research presentation. Clinical scoring for prediction of oxygen use in patients with COVID-19 infection in a community hospital, Thailand, a retrospective cohort study from Mr. Thanapat Vongchansathapat.
Good morning, respected professors and judges. Today, my topic of presentation concerns clinical scoring for prediction of oxygen use in patients with COVID-19 in a community hospital, Thailand, a retrospective cohort study. During the past couple of years, a new emerging virus named COVID-19 has been causing a pandemic. The severity of this disease comes with a wide spectrum, ranging from asymptomatic to critically ill patients. Many countries have suffered due to unprepared and limited medical equipment. Resource management is crucial for poorly developed areas. As many of you may have heard, the demand of oxygen tanks have been increasing due to the soaring number of infected people. Oxygen is a critical element in the treatment process of COVID-19 patients. Decreasing respiratory failures caused by COVID-19 depends on the availability of oxygen and ventilation. With shortage of supplies, this means that patients are receiving inadequate treatment. Even until now, we have to admit that COVID is still around us and is evolving into its best form. To prevent medical system collapse, patients likely to develop severe or critical illness should be identified and hospitalized. Previous studies and systematic reviews, especially from Dr. Highness in BMJ 2020, have proposed prediction models focused on COVID-19 diagnosis and prognosis in the general population. However, no model has been proposed to date for predicting the need of oxygen supply. To avoid the occurrence of lack of supplies in hospitals during this pandemic, our goal is to develop a prediction score for oxygen use in COVID-19 subjects in a rural setting where there is limited resource by using only the patient's background. This tool could be used to triage patients and to maximize resource management. This can also accelerate the process of resource planning and also avoid shortage occurrences. This research was conducted via retrospective cohort study in the year 2020 to 2022 from Sanam Chaiket Hospital. Confirmed COVID-19 patients from ATK or PCR were divided into two groups, one with oxygen use and the other with no oxygen use. First, multiple logistic regression with backward stepwise elimination was done. Score assignment was done. Score performance evaluation was included using measures of discrimination, measures of calibration, and measures of prediction. Next, internal validation with bootstrapping method was assessed. And lastly, decision curve analysis were also applied. The results for baseline characteristics showed that our total subjects were 2,192 in number, most of which were aged less than 60 years old and do not have comorbidities in the COVID-608 diseases. More than half the population received less than or equal to 1 COVID vaccines, and only about 2.3% needed oxygen therapy. 8 potential clinical predictors were identified. This included age more than or equal to 60 years, male gender, alcohol use, diabetes mellitus, cerebral vascular disease, cardiovascular disease, cancer, and COVID vaccinations. This was done by including the factors and then statistically analyzed using multiple logistic regression with backward stepwise elimination based on beta coefficient. Score assignment is shown on the right side of the column. Measure of score performance starts with measure of discrimination. This two figures shows that both AUROC from non-parametric and parametric turns out to be approximately 78%, or in other words, this means that the ability to differentiate the use of oxygen and no oxygen was 78%. Figure 3 demonstrates the distribution of subjects with oxygen use in yellow bars and no oxygen use in green bars. Step 2 in score performance is about measure of calibration. In Figure 4, the left side, the observed event showed concordance with the reference line predicted probability with an expected to outcome ratio of 1 and a slope of 1. Figure 5 shows that there is no evidence of over and under bisector and confirms the goodness of fit. The last step of score performance test is about measure of prediction. The x-axis is the risk score, and the y-axis is the risk of oxygen treatment. The circles symbolize the density of population. As seen, the circles coincide with the line of prediction curve. The cut point for oxygen use was calculated by using the turning points in the curve to find the value with the greatest area under the curve. And it turns out to be 2.5, with a sensitivity of 65 and a specificity of 74 and a discriminating power of 70%. Furthermore, internal validation was done using bootstrap performance with 200 replications and only showed 1% shrinkage. Lastly, decision curve analysis was done to test for clinical benefit. X-axis shows a probability of outcome. Y-axis shows a net benefit. Anything above the green line means positive benefit, whereas anything below means a waste of benefit. Using our score prediction model shown in blue line demonstrates positive benefit and clinical ability, opposed to the yellow line with no use of oxygen showed waste of benefit beyond the point of intersection. In conclusion, the Oxy score is an acceptable predictive scoring system where it can be potentially useful to help triage patients in a rural setting. And it hopes to provide optimal care and preventive management. The availability of medical resources, especially in times of a pandemic and the peak of number of infected, is an essential issue in managing hospital resources. An Oxy score calculator has been made for a better understanding of the picture. For example, a 65-year-old man walks to the ED with URI symptoms and COVID ATK was positive. He has these underlying diseases. All of you can feel free to scan the QR code. Once you open the calculator, a number of questions will be shown, and all you have to do is fill in the information. In this case, the patient score exceeds 0.5. This means that he is 2.5 times more likely to use oxygen compared to a person with a score below 2.5. Imagine being a doctor in a rural hospital with a capacity of 100 beds with limited oxygen supplies. One day, 200 patients come into your hospital. Wouldn't it be great if we could use these general patient information via the Oxy score to triage patients to where they should be in order to receive the health care that they need? Thank you.
Now we will proceed to question and answer sessions. Can I get a judge's question, please?
Good morning. I think it's very impressive and professional, especially in your statistical analysis in the modeling score. Have you shown the full equation model in your presentation, or it's a secret?
No, actually, we haven't included it in the model.
But can you explain what is the bootstrap internal validation process?
Yes.
I don't have other question because it's very perfect. So
okay, thank you. So internal validation is about seeing if whether the score that we have is really applicable in the data that we have in the population. So what we did was we sampled, for example, we started with 100% of the population. Then we simulated, okay, if we picked out like 80% or 70%, and then we want to see if the score is really consistent with the outcome. And so it turns out that even though from a sample population of 100%, it started with about 78%. And once we used with bootstrapping and we made 200 replications, sampled 200 times, and still it only shrinks about 1%. So it means that the outcome is really efficient and it's really applicable. Thank you.
And thank you.
Thank
you.
you.
Do you want to be a clinical statistician? Very, very impressive. And so the next step is external validation, right?
Yes,
your QR
that's
code?
Right.
Okay.
Yes, that's right.
Do we have another question from judges, please?
When you're using the data from the database that mentioned about requiring oxygen treatment, do you also identify the severity of the case also? Because when we use oxygen treatment, we have like a quite a spectrum to use. For example, like cannula use, or maybe intubate, or maybe using oxygen pressure. Because also in this case, it will also have the different outcome. That's why I'm wondering, did you also mention about this?
Well, first of all, this tool that we came up with, it's about just using the general patient information. We're not concerned about the patient's clinical, whether he is dyspnea, whether he has fever, what's his respiratory rate. So we're just concerned what's his age, what's his gender, what underlying diseases does he have. And so it's computed into a score. Thank you.
This is an up-to-date and related research to this pandemic era. Thank you for your presentation.